Officially, I'm retired, but I'm still working for 3 days per week. And I have 4 grandchildren, so there's more balance now in my life between work and between children and grandchildren. These are the topics that I want to discuss with you. Very briefly, what is C. diff? The treatment of Clostridium difficile infection, Clostridioides difficile infections. What is the susceptible population that we can approach for prevention measures? And some practical advices, also based on my experiences about 20 years ago, just as Gene Driscoll had on the O27 outbreaks and the new emerging strains that are now coming to Europe. You do have several, let's say, clinical pictures. First of all, the asymptomatic carriership, not important at all, we thought, because patients are healthy, are only colonized with C. diff and do not develop symptoms. Then the hospital-acquired diarrhea. The spores of C. diff are in the hospital. And they can easily spread from patient to patient and from patient to environment, cause colonization and cause disease. And the disease may vary from a very mild diarrhea, unrecognized, until a very severe form, the pseudomembranous colitis. However, there's also community-acquired diarrhea. Community-acquired diarrhea is diarrhea that is mainly associated with antibiotic use and develops outside the hospital. For certain groups of patients, it's easy to recognize it. The elderly patients that are treated with antibiotic and have been hospitalized, previously hospitalized. And of course, the C. diff infection can cause complications. And the complications may vary from overall mortality, 10 to 15%, relapses, 20% of all the patients relapse, a toxic megacolon, a perforation of the colon, and a protein enteropathy. In the Netherlands, it's a One Health issue, because many pigs in the Netherlands and many pig farms are contaminated with strains. And those strains, the O78 strains, are exactly the same strains that are now present as number 2 in our national surveillance. So it's an important One Health problem. And our hypothesis is that C. diff occurs in the community and is spread from the community to the hospitals and can spread in the hospital. So 2 problems of C. diff. First of all, the mortality, the overall mortality. And secondly, the high recurrence rate of 20%. So in the concept of C. diff, we use this model. So the older you are, the more comorbidity you have, the more antibiotics you use, or other medications that affect the gut microbiome. And the environment, for instance, the hospital, they determine if you can become colonized with C. diff, and the colonization can be very short or can persist very long. And the next step from the colonization could be the development of disease. However, we have already found that colonization is already associated with a disturbed microbiome. So not everyone, not all the healthy individuals are colonized with C. diff. You need some disruption of the microbiome already. And for the second step, the development of disease from colonization onwards, for that you also need some changes of the microbiome further. For the treatment of C. diff, there were very promising agents, but they have not been prepared for going to the market, or they were on the market, such as beslotoxumab, and were suddenly withdrawn without a clear cause. So there's a large anti-CDI graveyard. We only now have a few agents available. And this is an overview of the agents that are used for the treatment of the primary CDI and for the recurrent CDI. The primary, the initial CDI, and the patient with a first recurrent, or the patient with more than one recurrence of CDI. And you can see that there's only 2 antibiotics now, fidaxomicin and vancomycin. We do not consider metronidazole important anymore for the treatment of CDI. So vancomycin and fidaxomicin are used frequently, added also with features microbiota transplantation if you have multiple recurrent CDI and want to prevent a next episode. And how can you prevent a next episode of CDI? Sorry, it's after lunch. So this is basically the concept of a features microbiota transplantation, high reuse and sustainability, but you need to do it, of course, in a stool bank. And in the Netherlands, we do have a stool bank that started in 2014, 2015. And there are a huge number now of persons active in that national donor features bank. So we treat about 50 to 60 patients in the Netherlands per year with multiple recurrent CDI to prevent the next episode. And that is highly successful because more than 80–90% of all the cases are completely cured of their CDI episode, and there will be no recurrent CDI unless a new antibiotic is used. So you haven't disrupt microbiota, you recover by features microbiota transplantation, but if you then use a new other antibiotic for a urinary tract infection, for instance, then you see that, okay, the feces microbiota transplantation is not effective anymore. You look at the new episode of CDI, and we don't understand it completely, but we could see that after FMT, you do not eradicate C. diff. C. diff remains present in the stools. Even after 1 year, you can still find in a higher percentage than in healthy controls C. diff. 10 to 20% is still positive. So an FMT is important, but you have to combine it with antimicrobial stewardship. Okay, so the two agents, fidaxomicin and vancomycin, can we use those two agents for primary or secondary prophylaxis? Fidaxomicin is an ideal agent, isn't it? It kills the bacterium. It kills the spores. It inhibits the sporulation. And it also decreases the toxin production. So this is an ideal agent, especially since it's a small spectrum antibiotic. It does not work for the enterococci or for other aerobic gram-positive or gram-negative bacteria. It is only active against a small fraction of the Clostridium strains. So it saves the microbiome, and that's a very important property of fidaxomicin. But can resistance develop? Yes, it can develop, but it is very badly monitored, and we don't understand if it has clinical implications. So this is the largest study that I could find on resistance against fidaxomicin. It was an outbreak of fidaxomicin-resistant strains in a US hospital. They tested all fidaxomicin-treated patients and could find that about 5 to 6% was positive for C. diff. And they could associate that higher MIC values with specific mutations in the genes encoded for fidaxomicin resistant. But the strains were less fit. They did not grow very well. They produced less spores, and they also produced less toxin. So the clinical implication is a little bit uncertain. Okay, we go to the risk factor for CDI to determine if we can define a group that will benefit from fidaxomicin, vancomycin, or another agent. And that are, of course, the elderly in the first place, with comorbidity. Also patients with a decreased kidney function. The environment is important, for instance, the presence in a hospital. And also recent use of antibiotics, proton pump inhibitors also. So when a patient has CDI and you treat him for CDI, please stop immediately PPIs. And other factors that disturb the microbiome. So you probably all know that antibiotic use is extremely important, and two frequently used antibiotics are especially important: carbapenems and clindamycin. they highly predispose for C. diff. And cotrimoxazole, for instance, is a low-risk antibiotic that can be used both for children and for adults with a risk for CDI who should be treated from other infection. Can we now focus the prophylaxis with vancomycin or fidaxomicin or a specific group? So we have a group that has a chance to develop CDI, but can we, for instance, look for, are they colonized with C. diff? And if they are colonized, do then they develop an infection? Well, there are two studies, one from Denmark and one from the US, and they show that, patients who are colonized with C. diff have a 3 to 4 times higher chance to develop CDI. So yes, it may be good to screen susceptible patients for the presence of C. diff, and if C. diff is present, then to take appropriate measures such as an antibiotic to prevent the development of CDI. And there are risk factors, of course, when those colonized patients do receive antibiotic or are on the intensive care unit or do have underlying diseases, especially cirrhosis and malignancy. Yes, the chance is somewhat higher that they develop the disease. So how can you then prevent the CDI? The presentation this morning of Jane was excellent to see that, okay, first of all, there are key preventive measures, and please do not leave those measures. They are important not only for patient safety, but also for the safety of the healthcare workers, for the safety of the other patients in the ward, etc. Don't leave that. No other prevention can be done in those patients without the key preventive measures. Then we do the primary prevention. Can we just prevent CDI in all susceptible individuals, with or without colonization? And secondly, the secondary prevention. So when patients had a C. diff infection, can we then influence the development of a recurrence? There are several possibilities. Probiotics, for instance. Probiotics are frequently used outside the hospitals, but a large Cochrane analysis clearly demonstrates that probiotics are not effective for the prevention of primary or secondary prophylaxis. Only perhaps Saccharomyces boulardii, a yeast, can do something, but the data are far from complete. Fetus microbiota transformation, yes, very clear. Vaccination, I will come back to that. Prophylaxis with CDI antibiotics, I will also come back to that. And gut microbiome interventions. So this is the schedule that you should keep in mind. Primary prophylaxis and secondary prophylaxis. Fidaxomicin mainly also used for secondary prophylaxis. Vaccination only for the primary prophylaxis. Besletoximab withdrawn from the market only for secondary prophylaxis, and the FMT also. So what about vaccination? It's terrible, the vaccinations. I mean, there were 2 large clinical trials. These are the large clinical trials. One trial with more than 8,000 patients and another trial with more than 15,000 individuals. And it did not comply to the primary outcome targets. So both vaccines failed. However, if you do a subgroup analysis, yes, you can see that, okay, the second trial, especially from Pfizer, it failed, but the severity of the disease was less in the vaccinated people than in the non-vaccinated people. And they were not frequently prescribed antibiotics for CDI. Yes, that are the secondary outcome parameters, but until so far, they failed. And what could be a reason for that? Very simple, because the immunity against toxin A and toxin B is probably not so important as the immunity against other components of the C. diff bacterium. Everything has now been focused on toxin A and toxin B in these large trials, and I think that we should conclude now, okay, it's time to go to another vaccine with another composition. And one of the most promising vaccines is now an mRNA vaccine with other antigens than toxin A and toxin E, that has been tested in animals. Can we then use the prophylaxis with vancomycin orally? As primary prophylaxis or highly susceptible individuals, just give them vancomycin, or secondary prophylaxis after the first episode. And this is a meta-analysis published in a not so high impact factor journal, and that suggests that for the primary prophylaxis, vancomycin has a better effect than for the secondary prophylaxis. So it appears to work orally, vancomycin, but there is a heterogeneity among all the patients that have been included in the study, and sometimes the primary and the secondary prophylaxis has been mixed. After this meta-analysis, a trial appeared in the JAMA Open Network, and that suggested, okay, let us expand a little bit of vancomycin, let us change in the doses and the duration. So let us give it for 4 weeks instead of 1 week. So that seems to work very well in the Kaplan-Meier curve. You can see that the placebo was indeed a higher rate of vancomycin than of C. diff than in the vancomycin group, but this was the endpoint of the study. This was the endpoint, and this was the point that the vancomycin stopped. And when the vancomycin stopped, you see immediately an enormous increase of the CDI. So yes, vancomycin orally helps, but only when you give it for that period. And after that period, you will become susceptible again. And this is a study with the same data. And this was an interesting study that shows that, okay, maybe we should just screen by the microbiology for the presence or absence of C. diff. So this was done in an oncology hospital, and they screened all the patients for C. diff. And when the C. diff test was positive, they isolated the patient and we gave vancomycin prophylaxis. And indeed, there was a high an odds ratio of 0.15 for the patients that were treated with vancomycin to develop CDI in comparison with the placebo group. So yes, it helps. There were a few limitations in the study in which I will not go in further detail. Okay, so vancomycin probably helps. Vancomycin, when you give it in a high dose, for a long period of time, it helps to prevent the primary episodes of CDI and probably also a little bit for the secondary episode. But vancomycin orally is terrible. I mean, it's a broad-spectrum antibiotic that destroys all the beneficial bacteria, the firmicutes. So after the stopping of vancomycin, your microbiota is disrupted and you can become colonized with all kinds of multi-drug resistant gram-negative bacteria that can cause subsequent other infections. And no one is taking that into account in the study with a sufficient long period of follow-up. Fidaxomicin, in the studies for fidaxomicin, there's only one study that tested the fidaxomicin prophylaxis again in a group that was highly susceptible for CDI. And as the Kaplan-Meier curve on the right side shows, there was no significant difference. So this is pretty disappointing as a primary prophylaxis, the only study with fidaxomicin. And it was also disappointing to see that you can that the duration of vancomycin is quite long. So they started before the use of antibiotics and they ended after they had sufficient neutrophils in their blood. So sometimes more than 40 days. So the guidelines suggest in Europe, yes, okay, secondary prophylaxis may be done, especially if a microbiologist or infectious disease is involved. And also the Americans think that the secondary prophylaxis, yeah, there is some space for secondary prophylaxis. Finally, the microbiota. So now there are 3 different microbiota derivatives on the market. Or not on the market, 2 are on the market. 2 are commercial on the market in the US, so Rebiota and SER-109. And the other is still under development, but is now tested in a phase 3 study, the VE303. And that last agent is a bacterial community of 8 strains that have been selected based on the anti-C. diff activities in vitro. And of course, you can apply the fetus microbiota transplantation in patients that are highly susceptible of CDI, but that is currently not done, except for the patients who have an episode of CDI. In that group, it has been found in one study that after that immediate episode, performing a fetus microbiota transplantation may be very beneficial. And it's important to mention that this product, this bacterial community of 8 strains, is now tested worldwide in a phase 3 study. And we expect also that this agent will be used for the primary prophylaxis in the near future. It's a well-standardized formulation of 8 different bacteria, and that are available in a capsule. Okay, so finally, what is then the best prophylaxis for CDI? To answer the question, that is not the bestotoximab, because that's not available anymore. That is probably the microbiota intervention, or that are anti-CDI agents during antibiotic treatment. So that means, first of all, if the patient is at risk, especially after his first episode, for instance, is starting with new antibiotics again and is very fragile, yes, then it is possible to provide fidaxomicin as prophylaxis. I have not discussed the outbreaks, but also based on what Jean experienced and we have experienced in the Netherlands, yes, in an outbreak situation, everything changes. And it may be very wise in an outbreak situation just to go to patients to test the presence or absence of that emerging strain, and then to isolate the patient and to give him an antibiotic prophylaxis for the development of CDI. And I think that the future is especially important for the live biotherapeutic products, so for the bacterial communities. And at the same time, from the scientific point of view, yes, we need more information about what is exactly the trigger for the bacterium to go to colonization, to infection, what is the role of the host immunity, and what is the significance of CDI in children. So therefore I want to end, but I was very impressed by a patient organization, the Say Diff Trust in the UK, that has been initiated by 2 clinical scientists from Leeds, Carrie Davis and Jane Freeman. So all those matters, let's say, decisions also matters to patients, and the patient organization may be very helpful to get some information about their opinion on this too. I thank you for your attention.